I start recording. So thank you, Dr. Cristina Ferrone, for agreeing to present at our humble webinar today. Today, she will be talking about pancreatic cysts. And if this proves to be successful, we hope to have you present more talks in the future.
Wonderful. Well, thank you. I am honored to participate, and hopefully this will be interesting for the participants. And if you have questions, just feel free to stop me and ask me. This is very casual and I hope will be interactive. So if it's okay, I will share my screen, and that way we can get started.
We will, after you finish your talk, we will we'll start the questions after your talk. So to keep it like a bit organized.
Yep. Okay. However you would like. So this is a talk about cystic neoplasms. I don't have any disclosures. And so what I thought is I would start off with an overview. You know, at Mass General, we have a very strong pancreas history, and it was really started by Dr. Andy Warshaw, who was the former chairman, and now Keith Lillimo, who is the current chairman. And Carlos Fernandez del Castillo has dedicated really his whole career to IPMNs. And because of that, our whole group sees a lot of pancreatic cysts. And you can see of the almost 1,300 cysts that we've taken out, the different types of cysts, benign ones, malignant ones, and then ones that are epithelial or non-epithelial. And so let's see here. Oh, I apologize. And when you go into how these cohorts were divided over the decades, the workup has evolved tremendously. And I know that all the people on this webinar know this already because, you know, it has completely evolved, not only from radiologic imaging and then endoscopic. Ultrasound has become so much better, not only in terms of the picture that you get with the ultrasound, but the ability to do early on only FNAs, fine needle aspirations, and now microcores and larger biopsies. And of course, you know, the evolution of the molecular testing has an ability to better understand what kind of cyst it is. Because obviously something that's asymptomatic, like a serous cyst adenoma, we don't want to operate on. We want to leave that alone and let the patients be. And you can see how by decade, the diagnosis has changed of what we've taken out, and IPMNs are becoming more and more common in terms of what we're seeing and following. And part of that is because of all of the imaging that patients are getting for so many different reasons. And you can see here the different modalities that we have used over time and how they were diagnosed and classified. And I think this is just an interesting phenomenon to sort of see as we think about all of these pancreatic cysts and how we struggle to, especially with IPMNs, to be able to get them, you know, to operate on them at truly the right point, right? I mean, if we had our choice, I think all of us would say that we would operate on an IPMN if it was moderate to high grade dysplasia, right? So at a time right before it becomes invasive cancer, but is not yet invasive cancer. And of course, the criteria that we have now is not good enough for us to guarantee that for patients. And so what you can see is that as our modalities get better, our ability to make a diagnosis preoperatively has improved, but we still have a really long way to go, right? And, you know, if we're talking about a percentage in the 80s, that's not really acceptable, right? We really want something that's 95% or higher. And you can see that it does, the endoscopic ultrasound really is helping a lot, as is molecular testing, and it's happening more often, but of course is always costly. Let's see here. Oh, there we go. And as you would expect, the highest concordance is in IPMNs and neuroendocrine tumors, and mucinous cystic neoplasms and serous cystadenomas, and they're all less accurate. And I think some of that has to do with the ability of the pathologist to make the diagnosis, but also the frequency with which we see things. The more commonly we see things, the better we get at diagnosing it. And, you know, while EUS is the most expensive modality in many ways and the most invasive, it probably gives you the highest accuracy. So if you had to choose one test, and this comes up for us in conference a lot, you know, the radiologist always says, oh, I think, you know, the CAT scan's okay because the CAT scan was done for, you know, a kidney stone or for something completely different. You should get an MRI. And we have this discussion of, well, you know, should we really get an MRI to try to make the diagnosis, or should we go to an endoscopic ultrasound? Because in the end, while that's, even though it's more invasive, it'll give you a more definitive answer and will allow you to better counsel the patient. And I think it really comes down to, if you're going to take out the lesion anyway, then probably you need to do nothing else. But if you're debating whether you're going to take it out, an endoscopic ultrasound probably is more helpful than getting another radiologic imaging study. And then when you look at the different tumor types, this is just to show you some of the demographics that we see with these patients. And I think, as you would expect, a main duct IPMN, those patients tend to be the most symptomatic. And you can imagine, right, when the main duct is plugged with mucus, it causes increased pressure in the duct and can result in pancreatitis and abdominal pain, some jaundice, even, you know, diabetes early onset. And then when you talk about malignant to pre-malignant and benign lesions, you can see again these general demographics. But what you see is that about 45% are symptomatic. So the symptoms don't always allow you to differentiate between malignant and pre-malignant. And I think this just adds even more to this dilemma of, you know, when do we operate and how can we do a good job of picking the patients that we should operate on. And you can see that even the malignant ones are found in about half of the time completely incidentally. And I think that that's important. But you do see that the things that we see with pancreatic adenocarcinoma as well, and elevated CA19-9, is definitely something that requires a more, you know, probably a more aggressive approach because the chance of malignancy is higher. You know, we had hoped when we looked back at all of these cysts that maybe we could say, okay, well, if, you know, these cysts, the different cysts are going to be in different locations, and then we'll know, you know, that we'll be able to do a better job of getting the diagnosis. And you can see, you know, with main duct and branch duct IPMNs, about 60% are in the head versus 30% in the body and tail. MCNs, as you would expect, the majority, about 80% are in the body and tail. Serous cystadenomas are really divided equally. Neuroendocrine tumors, you know, we found very interesting, is about 70% in the body and the tail. So I think that these are all things to keep in mind, but it's not that you can say that if it's in one location, it is definitely one thing or the other. It just helps narrow it down a little bit. And I put this slide in here really just to remind everyone, especially if there are any non-surgeons on this webinar, is that while all of us enjoy operating, we are reminded by the patients who have complications why pancreatic operations are as high risk as they are, right? We know that when we operate on patients with pancreatic cancer, there is an operative mortality. Now, it's about 1%, and you say, oh, well, what's 1%? Well, it's only a big deal if you are that 1%, right? That patient who is that 1%, because for them it was 100%, because now they're no longer here. And so we want to make sure that we don't over-operate on patients, because it really is a big operation, no matter what part of the pancreas we're operating on. And so there's always these challenges in the management, observation versus an operation, the risk of missing a malignancy balanced by the chance of a complication, a lifelong diabetes, and the postoperative effects of a big pancreatic operation, including things like pancreatic enzyme repletion, ulcer management. And so this is where these IPMN guidelines, because I think that, I'm going to spend a lot of the talk on IPMNs, because I think those are the ones that we all struggle with the most. And I put up the 2 guidelines, and you'll see the similarities and the differences of these guidelines, right? So everyone agrees that when you're talking about high-risk stigmata, so patients where you really need to more aggressively think about an operation, jaundice is one of it. An enhancing mural nodule more than 5 millimeters. A main pancreatic duct bigger than 10 millimeters. Positive cytology for malignancy. Now, the European guidelines also put on there a solid mass. And I think that the reason the IAP, I think we would all agree that if you see a solid mass, it does increase the risk of malignancy. Worrisome features, the IAP guidelines are a cyst of 3 centimeters versus the European is 4 centimeters. They do agree on a main pancreatic duct of 5 to 9 millimeters, as well as a enhancing mural nodule of less than 5 millimeters. Those are all worrisome. History of acute pancreatitis, a serum CA19-9 more than 37. And here it differs again. The IAP, the cyst growth of more than 5 millimeters over 2 years, whereas the European guidelines say cyst growth of 5 millimeters or more over 1 year. Enhancing thickened cyst wall and presence of new onset diabetes. So you can see that the European guidelines are probably, they're a little bit more tolerant of the cyst size, so 3 centimeters versus 4 centimeters. And a cyst growth, it would have to be growing more rapidly for the European guidelines than the IAP guidelines. But in general, they all agree on these different points where you really need to consider being more aggressive about following the cyst. And so, excuse me, when you're talking about these worrisome features present, the question becomes, what about when you have more than one worrisome feature? What about 2 or 3 worrisome features? How can we figure out who to operate on? So this is a cystic lesion arising in the pancreatic neck, measuring about 3 centimeters in biggest dimension, likely a branch duct IPMN, slightly thickened and irregular enhancing wall, particularly on the right lateral margin. You have a CA19-9 more than 337, a size more than 3 centimeters, and a cyst growth rate of greater than 5 millimeters over 2 years, along with pancreatitis. So those are 4 worrisome features. And does a patient with 4 worrisome features have a higher likelihood of malignancy than a patient who has only 1 or 2? Right. And I think that this is always a big question, because many times the patients do have more than one factor that they want, that needs to be looked at. And so this was a collaborative study, and the patients were assessed according to the IAP Fukuoka guidelines. And what they looked at is how many worrisome and high risk features were seen in these 810 patients. And here you can see the patient characteristic. So 40% of the branch duct were here in the body and tail. The mixed were more in the body and neck, and 6% in the main duct, of only main duct, excuse me. And you can see 58% in the head and neck, versus the other half in the body and tail. And here are the operations that these 810 patients underwent. And so you can see how many patients had high-risk stigmata and worrisome features, and how many patients had none of the above, right? And the median number of worrisome features was 2 of the patients who were operated on, and then high-risk features was 1. And so when they looked at these patients, they saw that 12% invasive, 18% high grade, and 70% low grade. And you can see here that the number of worrisome features, as it increases, the risk of invasive cancer goes up. And that, of course, makes sense. I think that's what we would all predict. And so you can see here the percentage in the red is that of invasive cancer. And so, as you would predict, it goes up. Now, what about the 810 patients who had high-risk features? You had 45% with invasive, 28% with high grade, and 27% with low grade. And again, the number of high-risk features, as that goes up, the chance of having an invasive cancer also goes up. And so when you compare the worrisome to the high-risk stigmata, you can see that 3 worrisome features is equivalent to 1 high-risk feature in terms of the chance of having high-grade dysplasia or an invasive cancer, right? It ends up being about 60%. So if you're seeing a patient in the office and they have 1 high-risk feature and they say, well, really, what is my chance of needing this operation because I have high risk or invasive? We can say it's about 60%, just like if they have 3 high-risk features. Now, if they have, worrisome features, whereas if they have only 1 worrisome feature, it's only about 20%. And I think these are just nice numbers to keep in mind as you're talking to patients, as they try to weigh the pros and cons of the timing of having an operation. And so here we have our case again. The patient had 4 worrisome factors. They underwent a distal pancreatectomy and splenectomy with an uneventful postoperative course. Now with the 4 worrisome features, there's almost 100% chance of malignancy. This patient did not end up having it, but did have the high-grade dysplasia. So just in the nick of time, as we like to say. But I do think that while not perfect, it is a nice guide for us to figure out how we want to be able to take care of our patients. So while more pancreatic cysts are being diagnosed and our diagnostic accuracy is improving, we still have a significant amount of work to do. And the hope is really, can we figure out with our endoscopic ultrasound and getting the molecular profile, can we do a better job so that it's almost 100% sure that we will only resect patients with high-grade dysplasia or invasive cancer? 3 or more worrisome features present a similar risk to 1 high-risk feature. And an IPMN with increasing numbers of worrisome features, 22, 34, 59, 100% risk of high-grade dysplasia or invasive cancer as the numbers go up. Just like the patients with high-risk features, it goes from 63 to 82 to 100% chance of having high-grade dysplasia or an invasive cancer. And so this is really our team. It's our team of surgeons. It's our team of medical oncologists. Our pathologists are absolutely essential to being able to make these diagnoses, because without them, we can't really do anything at all. And so I know this is a fairly short talk. Part of it is unfortunately, I got COVID while doing my duty of call and have a fever. And that's why my voice sounds somewhat strange. So I apologize for that. But thankfully, through Zoom, you can't catch my COVID that I got at work and tested positive last Friday. But I'm more than happy to take any questions that you have, or if you have any cases. If you want, I can go back and put up some of what might be helpful if people have questions. I could put up the paradigm where we look at the different IAP versus European guidelines. I think that in many ways is the most helpful when talking about any patient cases, if you have any patient cases you wanted to bring up or questions you have.
Thank you, Dr. Cristina, for this marvelous talk. It was short and to the point. We can start by, let's see if any of the audience has any questions. Please, if you have any question, raise your hand. Dr. Medhat Khafaga.
Okay. Thank you for your lecture. My question is that, how about the prognosis of carcinoma and IPMN as regards the overall survival in relation to carcinoma of head of pancreas?
Right. And
is
so
it
when you,
better? I think it is better, but how better?
it's not much better. So once you have true invasive carcinoma, most of the patients have positive lymph nodes and their prognosis is not much better than standard adenocarcinoma.
It's the same. But
It's
if there is
essentially the
negative
same.
nodes,
Yeah.
if there's negative nodes.
If it's negative nodes, then they do better. Just like with pancreatic adenocarcinoma, when they have negative nodes, they do better. The question is always, it's very uncommon, unfortunately.
It is the same, you mean? So whether it is negative nodes or positive nodes?
No, positive nodes is much worse. Positive nodes is much worse.
Okay.
It's the same as adenocarcinoma, she said.
Yeah, the same as IPMN with invasive cancer or adenocarcinoma is essentially the same in terms of prognosis.
Okay, thank you.
Dr. Walid.
Hello, thanks a lot for your wonderful presentation, and we wish you get well soon.
Thank you.
Okay, you're welcome. I would like to ask you if you can give us a brief idea about the molecular analytical tests for the pancreatic cysts.
Yeah, so the ones that we've been looking at is KRAS and GNAS. And the problem is that while we're collecting all this data, we have not been able to make a predictive model that is accurate enough. So it's hard to say, okay, well, if you see a KRAS G12 mutation, the chance of invasive cancer is, 95%. So we have not been able to do that. We're collecting all of the data. And so when the patients go and get an endoscopic ultrasound, they're getting a molecular analysis. And so we're just accumulating all this data. And hopefully in the next, 2 to 3 years, we can make some kind of conclusion about the molecular profile that we get from the endoscopic ultrasound and the aspiration of the fluid.
Okay, thanks a lot.
Dr. Mustafa Shazli. We can't hear you. The connection is. Dr. Mustafa, we can't hear you.
Maybe they could type it in the chat.
Yeah. Dr. Mustafa, please type your question in the chat. We cannot hear you. No, it's not working. Okay, Dr. Kamal Ali. Can you hear me? Dr. Kamal, please unmute. Right. Dr. Ahmed Mustafa.
Um, First, thank you for your lecture, and I hope you get well soon.
Thank you.
My question as regards the quality of life after total pancreatectomy, the patient survival, patient problems. We don't do total pancreatectomy in Egypt. So how can we start? Any preparations, any precautions? What do you think?
Yeah, so I will caution you, the life of the patient with a total pancreatectomy is so difficult. They're such a brittle diabetic, and they really need to be a patient where they are very proactive and they have a significant amount of support. I have to say, we don't think that we think there's almost no indication to do a total pancreatectomy. I mean, it's really very rare that you have a main duct IPMN where let's say you have a main duct IPMN, you plan to do a Whipple and you do the transection margin and the patient has still high-grade dysplasia or invasive cancer all the way to the tail of the pancreas. I mean, I have to say, it is so rare for us. And, you saw our numbers of total pancreatectomies we've done. It's negligible. But what we do is we have the patient meet with the endocrinologist and an endocrinologist that hopefully they can follow up with very regularly. And then also they have to be prepared to take pancreatic enzymes in addition to managing their brittle diabetes. And the pancreatic enzymes, and I don't know in Egypt how expensive they are, but in the United States, they are so expensive, it becomes almost financially crippling for patients to pay for these enzymes because the insurance will cover a little, but not enough. And so the patient also needs to have enough resources to be able to pay for these enzymes and for all of the medical care. So I would say that there is almost no indication for doing a total pancreatectomy.
But you can do an extended Whipple with the aid of frozen section to the margin, or no need?
Yeah, so we do a frozen section. I know it gets heavily debated at the surgical meetings whether you should or shouldn't do a frozen section. But our feeling is if you transect the pancreas and you have a pathologist who is comfortable reading it on frozen section, you just feel better knowing, okay, fine, even if there's IPMN, but it's low grade, that's okay, because that may be another 15, 20 years before it develops into anything more serious. And the patient's already in their 70s. So, chances are that's not going to be a problem. But you will ruin their life by doing a total pancreatectomy.
Yeah. Yes. Okay. But if you leave a small part of the tail, do you re-anastomose it or you just close it?
No, we re-anastomose it. Because even a small amount of pancreatic enzyme helps, right? And the problem is when you sew it off, it then completely atrophies because it can't drain. Whereas if you anastomose it, even if it's a tiny little piece, it gives you some functioning pancreas. And our feeling is a little bit is better than nothing.
And what type of anastomosis do you do? What type of anastomosis? Do you do a ductal mucosa? It's small.
Yeah, we do a ductal mucosa, pancreaticojejunostomy.
Okay. Thank you. Thank you so much.
So I think the question was, what's the minimum length? Exactly. I mean, I would say, about 3 centimeters is the minimum length.
So minimum length where you don't have to start substituting pancreatic enzymes and so on.
No, you probably will still have to substitute it. It also depends on the health of the pancreas, right? Because sometimes when the duct has been obstructed for a long time, you've already begun to have atrophy. And so the parenchyma is not healthy anymore. But even if you're sparing the patient a little piece, we always feel it is better than just taking everything out. And I know that there are some groups, they love to just take out the whole pancreas. They say, oh, then you don't have a pancreatic fistula. I say that's that's a high price to pay for a short-term benefit. Because the pancreatic fistula, it's a short-term problem. The pancreatic fistula isn't a long-term problem. I mean, we're probably the other extreme at the Mass General. Like we do a lot of central pancreatectomies. right? For cysts, we'll do just the central portion out. And when you talk about pancreatic fistula rates, it's twice the pancreatic fistula rate because you sealed off the neck, right? Like a distal pancreatectomy. And you have the pancreatic angiogenostomy to the body and tail of the pancreas. So you have two anastomoses to leak from. But your risk of diabetes, your risk of needing pancreatic enzymes goes down. And we say it's a short-term price for a long-term benefit.
Okay.
For one final question, please. As regard the workup in the cyst fluid, you do cytology from the cyst fluid and you send it for CEA or whatever?
Yeah, so exactly. So we send it for CEA and then we do the cytology. And I think sometimes for CEA, people say, oh, well, if the CEA is over 180, it's malignant. No, a CEA of 180 only means it's mucinous, right? It doesn't mean that it's malignant or not malignant, but it says, okay, this is a mucinous cyst. So either an IPMN or mucinous cystic neoplasm and not a serous adenoma or another cyst.
Yes. Okay. Thank you so much. Thank you.
Sure, of course.
Let's try Dr. Mustafa Shazli.
Are there things in the chat maybe?
Yes.
Dr. Mustafa?
Can you hear me now?
Sort of, yes.
Yes. Can you hear me?
I believe your question is about pseudopancreatic.
Solid
Pseudopapillary
pseudopapillary tumors?
Yeah.
I'm sending a message. I sent a message.
Yeah, the question
you
about
said
solid pseudopapillary
pseudopapillary.
tumors?
We can't hear.
I mean, maybe I could just, so the solid pseudopapillary tumors, you know, they tend to be in younger women. And oftentimes the women do present with symptoms and they can get to be fairly large. And then I think there's a question about data regarding the relationship between degree of diabetes and the site excised from the pancreas. I think it, you know, what, you know, they say that there are more islets in the body and tail of the pancreas, depending on, you know, the health of the pancreatic tissue. I think a lot of it depends on, you know, many of the patients in the United States that run into problems is because they're overweight and they were already borderline diabetic. And then we take a good portion of their pancreas out and then they're tipped over the edge. When we did the study on 5-year survivors after a Whipple operation and their quality of life, it was 7% of patients who had new onset diabetes, i.e. they did not have type 2 diabetes prior to the operation. But realistically, when we look at the patients who are getting pancreatic operations, many of them are already on metformin or glucophage or one of the other oral agents.
Okay, we have a Dr. Nabeen.
Yeah, okay. Nice to see all of you. Thanks, Dr. Christine. I have a question. I'm a radiologist, okay? And I wanted to ask about a step of using MRI in your practice. Is it a pre-operative for local staging or it is a routine for diagnostic purpose?
So I think that's a great question. So we will, for preoperative staging, a lot of times we get a pancreas protocol CT scan because it is, the patients like it better because they're on the machine less time The healthcare system likes it more because it's less expensive. For the patients that we are following for IPMNs year after year, we like to get an MRI with an MRCP, mainly because it, you know, if the patient is able to hold their breath and you have beautiful pictures, it's very accurate and the patient gets no radiation. So for that reason, we like the MRI, especially if the patient is on the younger side.
Okay. I have a question about the indications of resection of serous adenoma.
Yeah, so for serous cystadenomas, I mean, there really is no malignant potential. So the only time that we really advocate to take them out is if someone is symptomatic. So, you know, if someone has a big body tail serous cystadenoma, where it really is pushing on the greater curvature of the stomach and the patient is having early satiety and possibly weight loss or a lot more indigestion, we'll consider removing that. Or if they have a serous cystadenoma that has been growing over time in the head of the pancreas that now is causing biliary obstruction. But otherwise, if it's a smaller serous cystadenoma, the size doesn't matter. It really only comes down to symptoms. It's not like neuroendocrine tumors where we say a 2 centimeter neuroendocrine tumor, we would like to resect.
Okay, thank you. And Dr. Ahmed Mustafa, another question.
Okay, thank you again. You mentioned that we may ask about clinical cases. And you did a lot of central pancreatectomy. I had a middle-aged female patient with a papillary serous solid tumor in the neck, large one. After resection, I had to ligate the splenic artery and vein, and there was only 2 centimeters at the head, and the big amount of the tail, which was okay. Then I have 2 choices: either to do a central pancreatectomy or to remove the tail. And actually, my question, after ligation of the splenic artery and vein, the body and tail, what are the blood supply? Actually, I did central pancreatectomy and I put the pancreas in the stomach and the patient did well, but I was very concerned about the vascularity of the tail after and body after ligation of the splenic artery and vein. What do you think?
You know, I think that I would have been equally, you know, concerned about the viability of the body and tail, but I think that it goes back to the collateral vascularization off of, you know, the short gastrics and the spleen being able to keep the body and tail alive, right? Because realistically, it probably shouldn't have been able to stay alive, but it clearly did. And the patient, sounds like the patient did very well.
Yes, and it was okay. And I followed the pancreas through the gastroscopy.
Yeah.
But still, if I am in the same situation again, what do you advise? Should I remove the spleen? Should I leave the spleen? What's your
advice? Yeah, the spleen, I'm not so worried about, right? Because as long as the patient, you know, when you ligate the splenic artery and vein, we know from Dr. Warshaw's experience and the Warshaw operation, you can take the splenic artery and vein as long as the short gastrics are in place, the spleen will stay alive. What we found is the time when the spleen tends not to stay alive is people who have significant cardiovascular problems and people who are big smokers. Because I think that they have a lot of microvascular changes that we can't always appreciate. But the reality is that if you ligate the splenic artery and vein, and as long as the spleen looks somewhat pinkish purplish, it looks darker. It looks much, much darker. And there are days when you say, oh gosh, I really hope this is okay. But the body is good, right? Like the body does a good job of salvaging many things that we do to it. But then the spleen can stay. And I'm assuming that your body and tail of the pancreas probably continue to have its viability.
Yes, but in this case, I had to remove the spleen. I don't remember why. It was many years ago. But my question, if you are in the same situation, what should you do?
I don't know if I would have been as bold as you. I think I would have been more scared. I would have been like, I better just take it out. But you did the right thing. But I can't completely explain how it continued to have adequate vascular supply. But you know what? It did. So therefore,
it's okay.
You did a good job.
Okay, thank you. Thank you.
But the question of, with central pancreatectomy that we often talk about is it better to do a pancreaticogastrostomy or a pancreaticojejunostomy? And I think that there are pros and cons to both. The nice thing about the pancreaticogastrostomy is it tends to leak less, right? So the fistula problems are much lower. The downside is that when the pancreatic enzymes from the body and tail go straight into the stomach, the acid neutralizes them quickly. And so they don't get the pancreatic enzyme benefit, but they still have their head and part of the neck. And so they should hopefully get enough from, via the ampulla.
Yes, okay. Thank you.
So what you're saying is that you wouldn't anastomose it to the stomach, you'd anastomose it elsewhere? Or...
No, I think it all depends on the anatomy, how much body tail is left, right? Because sometimes we do a middle pancreatectomy, but it really is in sort of the mid-body. And then there's not a lot of pancreas left distally. And you say, well, the enzyme component from that is not very high. Let's decrease our fistula rate, and you put it into the back of the stomach. Sometimes, even when you want to put it in the back of the stomach, just anatomically, it will not, the way that it lies in the body just doesn't seem like a good angle. And so then you just do a pancreaticojejunostomy. I think that if there's a lot of body and tail left, I think it's worthwhile to do a pancreaticojejunostomy.
Okay.
Thank you.
Of course.
Question from Dr. Mustafa. In case of central pancreatectomy, do you close the duct proximally? What do you do if there's a leak postoperative?
So you're saying from the head and neck of the pancreas? We close it the way that we close things for a distal pancreatectomy. Honestly, usually with a stapler. So we leave the head and neck, and then we just divide the neck of the pancreas with a stapler. I tend to use the tri-stapler, the one that has the 3 rows of staples, all of different heights. I don't use a seam guard or any kind of reinforcement because there's no data to support that, and it increases the cost. I wrote a paper probably about 12 or 14 years ago, and I went through our entire MGH database, and we looked at all the ways that we tried to close the pancreas, from sewing it with different kinds of sutures, glue, microwave ablation, acid burn, stapling with a seam guard. You name it. And we looked at all of the data, and the bottom line was the same. Between 22 and 24% of the patients leaked. And that was it. It didn't matter how you did it. So I think really whatever way you're comfortable with. I always leave a drain. I know some people don't leave a drain. My feeling is I'm there, I'm going to leave a drain, and I put it to suction. I use like a 19 Blake or a Jackson Pratt drain. I put it to suction overnight, and the next morning the residents switch it to a gravity drainage bag, so you're not sucking on the end of the pancreas. And then that way, if there is a leak, it's taken care of, and you don't have to have another one, have another drain put in.
Okay.
If it still leaks, what do you do? So you mean the drain's in place, but the patient is otherwise fine? Honestly, we just have them go on a low-fat diet and we wait. For some of the patients, we have used octreotide with mixed results. I know that Peter Allen published the study on panreotide, which is a more expensive, long-acting somatostatin inhibitor, but it's so expensive. And we didn't think that the result was dramatic enough to justify that cost.
Okay. Do you have any other questions? Any? Dr. Mustafa asking in case of suspecting insulin, what do you do?
Oh yeah, the insulinoma, because so many of them tend to be so small. So we tend to do a dotatate PET scan to help localize the insulinoma or any really small functional neuroendocrine tumor. But you're right, if you can't find it, even with an ultrasound in the operating room, it's a real problem. Because the question is always, well, should you just blindly resect? Well, it's a big leap of faith. But of course, these patients are so unhappy and so miserable. You do feel like you need to do everything you can. So we usually do, a early arterial phase CT scan to see if we can see it light up. And then we do a dotatate PET to see, hopefully, if we can get it there. We have the gastroenterologists do endoscopic ultrasounds and see if they can find it. And if they do find it, we have them leave a little tattoo right where they think it is, so to help us find it. But the insulinomas, because so many of them tend to be so small, but yet cause so many problems. They're tough. They're really tough. But when you do find it, oh my gosh, those are the happiest patients you'll ever meet. So we don't test for insulin intraoperatively. We just don't have that. You would think we would have a great setup, but we don't. After resection, you mean that once you remove the tumor? Yes. So once we think we've gotten it, you can test it, but the problem is the test doesn't come back that fast. So what we usually do is we send it to frozen section pathology and see if they can find the lesion under the microscope, because they can see a neuroendocrine tumor.
Okay, thank you. I think considering that you still have COVID, I think you've had enough questions for today.
Well, thank you. But thank you everybody for attending. I know 9 o'clock at night. It's also late for now, almost 10 o'clock at night.
Okay. Thank you, Dr. Cristina, for today's webinar. And I really hope we can have a chance to do another one later. So
yeah, I'd be more than happy to come back again, and I'll make sure that I also send you the names of some of my colleagues. So thank you all for attending. Greatly appreciate it.
Thank you, and get well soon.
Thank you. Bye-bye.
Okay, good night. Bye-bye. صباح على خير.